good evening. My name is Florida Uzuaro, and I am an assistant professor with Southeastern Louisiana University. Today, I am here to present a paper that my colleagues and I published last year in the Annals of Public Health and Research. I have included information about the paper here in the presentation, as well as included a link for those who would wish to get the PowerPoint presentation. This is actually linked in it. So, and this is for those who are interested in learning more about the study. So, this slide is the abstract that just basically summarizes the key points that we'll be talking about in the presentation, but also some of the key points in the paper as well. And for this presentation, I'm going to be focusing on looking at the introduction, the method, the result, and conclusion. And let's just get to it. So for over the years, there's been a lot of work that's been done in the area of HIV and HIV testing. Uh, Traditionally, HIV testing has been something that is facility based, or in sub-Saharan Africa, this is quite common, where you have community based events like health fairs, and you also have mobile testing, whereby you have people who go around testing people in their homes. However, these traditional ways of testing HIV typically does not provide a lot of privacy, which can be quite challenging for young people who are very much an at-risk population, especially given that HIV is a highly stigmatized infection. So, as such, this relative lack of privacy in those traditional methods of testing can act as a barrier to testing for young people. So this is one of the many reasons why the WHO has been pushing for HIV self-testing, because among other things, it does assure young people more privacy and confidentiality. However, regardless of how much this push has been going on, to the best of our knowledge, we could not find an instrument that was measuring young people's attitude towards HIV self-testing, which was a gap that our paper sought to address. So there are a number of 16 validated instruments that have been measuring different constructs that are related to HIV self-testing. An example would be the fear of HIV scale, and some of the ones that I've included in this presentation. But very few of these scales have focused primarily on HIV testing, one of which is the HIV antibody testing attitude scale, which I will henceforth refer to as HTAS. So we chose the scale for our study. Because one, it was the one that was measuring testing, but another reason that we chose this scale to use for the study was because this instrument had actually been validated in Nigeria, and not just that it was validated in Nigeria, it was validated among our population of interest, that being young people. So for our study, we kind of focused on two constructs. First was accepting attitude towards HIV self-testing among young people. The second was, measuring young people's intention to use HIV self-testing kits. And the construct that we chose was supported by the theory of planned behavior. This theory has actually been used in measuring behavioral intention, and it's kind of looked at three functions. It's looking at attitude, it's looking at subjective norm, and it's been kind of looking at perceived self-efficacy. So like I said, it's being used in testing intention, measuring for intention to test for HIV in the past, which kind of supported our decision to use it. So the objective for our study was to develop an instrument that was specifically looking to measure, intention to intention to use HIV self-testing, and also attitude towards HIV self-testing. And so to do that, we looked at adapting and validating the ATAS, which is the HIV antibody test. So to do that, we used two approaches in our method. The first was in adapting the HDAS for use in HIV self-testing. Like the ATAS was not designed for HIV self-testing, so we needed to kind of adapt it so that it could be used for HIV self-testing. And the version of it that we used was the 2020, the 2004 instrument, which came from 32 item instrument. So this 22 item instrument scale was actually there was a psychometric test of it that was carried out in many countries in sub-Saharan Africa, of which Nigeria was one of it. So the second arm, or the second part of our method, was to do a content validity of the adapted scale. Here we kind of use convenient sampling to recruit 6 subject matter experts who were academics and program specialists in sexual health, behavioral science, and HIV. So these subject matter experts were asked to make judgments on each of the items on the validated scale, whether or not they considered it to be essential, useful, not necessary. Again, we were interested in measuring 2 constructs, which was related to attitude towards HIV self-testing, as well as intention to use HIV self-testing. So they were also asked to kind of comment on the wording of the items in the scale, in the adapted scale, and to suggest additional items if they felt that what was in the adapted scale could be better measured with another item, measure the contract with another item. So for the data analysis, the adaptation side of it kind of involved analyzing the 22 items, kind of looking at it in terms of its use of plain language, the use of active voice, or whether or not the item could be applied to HIV self-testing. Like I said, the HDAS was not designed for HIV self-testing, so there needed to be some kind of adaptation to kind of make it such that it could be used for HIV self-testing. We also did a narrative analysis of the items to kind of identify themes that we're kind of looking at in terms of whether they were facilitators of HIV self-testing or they were barriers to HIV self-testing. So for content validity, the feedback from these subject matter experts was whether how many of them rated an item to be essential versus useful versus not necessary. So an item was to be rated as essential if the SME considered that item to be vital in measuring young people's perception and attitude towards HIV self-testing. And an item is to be considered useful if the SME felt that this item was going to provide important information on young people's perception and attitude towards HIV self-testing. Then on not necessary was if the SME felt that even if that item was removed from the scale, this instrument will still be able to adequately measure young people's perception and attitude towards self-testing. So the decision on whether to keep an item in the adapted scale or to remove it was based on whether it received a rating of essential or useful, which is to say that an item had to have received a rating of essential or a rating of useful to be retained. Otherwise, if it didn't receive that, it was going to be dropped from the scale. So in addition to whether or not it received the rating of essential or useful, we also used variance in the feedback from the SMEs in determining what item was to be retained and what item was to be dropped. For instance, if there were disagreements among the SMEs on whether an item was essential or whether an item was useful or was necessary, the decision on whether to keep that item in the scale was based on how many people rated it as not necessary or vice versa. That bit. So if, however, if an item received a rating of not necessary by most of the SMEs, in which case we were using over 50% of it, then that item was going to be dropped, regardless whether it had, rating of useful or essential. So let's get to the results. I'm going to look at this tables. So table 1 here, it shows the theme that we identified from the narrative analysis of the adapted 21 item HIV scale. Initially, we identified 4 themes. We had confidentiality, we had social support, we had social acceptance, and then interaction with the HIV, with the healthcare professionals or healthcare system. As you can see, there were a lot more items that we identified. Sorry, I kind of missed something. And then after we had kind of had this 4 themes that we identified, we then kind of further, got it all together by separating it between what we felt, whether they were facilitators of HIV self-testing or they were barriers to HIV self-testing. As you can see from the table, there were much more items that we identified as being barriers, or they were measuring barriers to HIV self-testing versus those that we are measuring facilitators of HIV self-testing. So table 2 is showing the content validity from the SME's feedback. I'm not sure if you can see this. So the item that received the most rating of essential from SMEs was the one that looked at it would be embarrassing to get an HIV self-testing kit. All 6 of the SMEs rated that as being essential. And then another item that received a lot of rating of essential was HIV self-testing is not really confidential. 5 out of the 6 SMEs rated it as being essential, while 1 rated it as being useful. The item that had the most rating of not necessary was I can talk to my friends about making medical decisions. 50% of the SMEs rated it as not being necessary, while 50% rated it as being useful. So, however, the item was retained in the final validated scale, in the final adapted scale, because it didn't meet the threshold of having more than 50 SMEs as rated it as being not necessary. So we kind of kept it in it. So this is the final draft of the adapted HIV self-testing attitude scale. As you can see, this is kind of a comparison between what the HTAS looks like and what the adapted scale looks like. So you can see that there was quite most of the work that we did in the adaptation part of it was having to trying to make sure we were using the right language for HIV self-testing. An example would be one that says HIV test information is kept very confidential by medical staff who do the testing. We then adapted it to say HIV self-testing information is kept very confidential by medical staff I share the results of the test with. Another example, showing how we adapted the language was the one that said, my friends would look down on me if I were tested for HIV. We adapted that to read, my friends would look down on me if I were to get an HIV self-testing kit. So only one item was actually dropped from the HTAS. The reason we dropped, and that item was I do not have time to get an HIV test. So it was dropped because one of the selling points of HIV self-testing is the convenience in the sense that young people get to be able to test at their convenience where they feel comfortable maybe in the comfort of their homes and stuff. So we kind of felt that item did not apply to HIV self-testing, so it was dropped from the scale. So, I don't know why this is happening. I'm sorry. Let me go to the conclusion. For some reason, this is happening. All right. It's taking me elsewhere. I'm sorry. Anyway, in conclusion, uh, developing an instrument that examines the attitude towards HIV self-testing among young people would really help in revealing a true sense of the perceptions that young people have, and young people's perspective about HIV self-testing and their intention to self-test, to also help in identifying the barriers and facilitators that go into and by so doing aid in identifying ways that we could help in overcoming those barriers to testing, especially given that a lot of the items on the validator scale were basically measuring barriers to testing far more than it was measuring facilitators. I mean, both of them combined is something that really gives a much whole picture of it, but it does provide very useful information. So for implication for practice, while this is not the final stage of that goes into developing a validated instrument, the findings from this study does provide some insights to how practitioners can examine young people's attitude towards HIV self-testing, especially because we do not have an existing validated instrument right now. While we're going through the process of actually validating it, it does provide some useful language that practitioners can use in identifying where areas of need or areas that they should kind of focus in attention to, particularly for health professionals or educators that are collecting and providing additional knowledge and insight on preventive interventions that is going to help promote positive health outcomes. So thank you. This is the references that's in the study, just a few of them, and this is my contact information. Like I said, I am. Thank you. I don't know what's going on with this. Yeah, thank you very much.